This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we are diving into the critical window of post-operative care.
And I'm Dr. Alara, research fellow. Today we're looking at a fascinating new study from a 2026 issue of BMJ Open titled Development and Validation of 3 Risk Prediction Models for Clinical Deterioration of Patients After Craniotomy, a retrospective cohort study in China.
This is a topic close to every neurosurgeon's heart, or perhaps I should say every neurosurgeon's blood pressure. We all know that the hours following a craniotomy are some of the most volatile for a patient. We've all seen cases where a patient seems stable on the ward, only to have an unplanned transfer to the NICU a few hours later.
Exactly, Dr. Aris. The paper notes that clinical deterioration, which they define as a change from one clinical state to a worse one, often leads to serious adverse events. In fact, they cite an American database analysis of over 38,000 neurosurgical patients, showing that complication rates are significantly higher after craniotomy compared to spinal surgery. Even more striking is the mortality rate for unplanned transfers to the neurological ICU, which can be as high as 17%.
17% is a staggering number for an unplanned transfer. The key, as the authors suggest, is early identification. But the tools we've traditionally used have their limits. Alara, walk us through why the authors felt we needed a new model. Why aren't the Glasgow Coma Scale or the Apache scores enough?
It's a great question. The paper argues that while the GCS is our bread and butter, it only reflects eye-opening, verbal, and motor responses. It leaves out vital physiological parameters, and as we know, it's difficult to use in aphasic patients. Then you have the Apache score, which is excellent for predicting mortality, but it isn't necessarily designed to catch deterioration before it happens on a general ward.
And what about the Early Warning Score, or EWS? Many hospitals use that as a standard.
The authors point out that EWS is a bit too simple. It uses heart rate, systolic BP, respiratory rate, temperature, and consciousness, but it omits critical indicators like age and specific underlying conditions. Essentially, current tools are either too general or they focus on the end prognosis, rather than the process of deteriorating. So this study sought to create something specific for the post-craniotomy population.
Let's get into the how. This was a massive undertaking in China, wasn't it?
It was. They conducted a retrospective cohort study across 3 large tertiary hospitals in Hunan province, all affiliated with Central South University. They looked at 1,576 patients who underwent craniotomy between January 2018 and March 2020.
That's a robust sample size. How did they handle the data?
They split the patients into 2 groups, a training set and a validation set, using a 7:3 ratio. They collected comprehensive demographic and disease-specific data, not just the basics, but the kind of granular detail clinical nurses see every day. Then they didn't just build one model, they built 3 using different methodologies: logistic regression, Bayes classification, and a backpropagation neural network, or BPNN.
Machine learning in the neuro ward. I like it. Before we get to the winner of those 3 models, what were the actual results? How well did these models perform in identifying the patients who are about to crash?
All 3 models performed respectively, but the backpropagation neural network, or the BPNN, was the clear standout. In both the training and validation sets, it showed the highest efficiency.
Give us the stats. Our residents are going to want the specifics on sensitivity and specificity.
For the BPNN model, the sensitivity was 77.1%, and the specificity was 91.7%. The overall correctness was 86.8%. It also had a positive predictive value of 82.3% and a negative predictive value of 88.9%.
Those are impressive numbers, especially that specificity. In a busy neurosurgical ward, you don't want a tool that cries wolf every 10 minutes, but you also can't afford to miss the patient who is slowly developing an epidural hematoma or worsening edema.
Exactly. To choose the best model, the researchers used something called the technique for order preference by similarity to an ideal solution, the TOPSIS method. It's a way to evaluate the efficiency of the models comprehensively. And across the board, the BPNN outperformed the Bayes classifier, which actually had the lowest predictive efficiency of the 3.
Let's dive deeper into why the neural network model, the BPNN, works so well. What makes it different from a standard logistic regression?
The paper suggests that the BPNN is better at handling the complex nonlinear relationships between variables. Think about a post-op patient. Their blood pressure might be fine, but their respiratory rate is slightly up and their GCS is down by just 1 point. A linear model might not see that as a red alert, but a neural network can recognize the pattern of those indicators working together to signal a coming deterioration.
It mimics the clinical intuition that senior nurses and attendings develop over decades, but it puts it into a standardized technical reference. The authors specifically mention this as a tool for clinical nurses, right?
Yes, they emphasize that nurses are the first line of defense. They are the ones providing direct care and monitoring these physiological parameters. By using a model like the BPNN, a nurse doesn't have to rely solely on subjective judgment or clinical experience, which we know can vary wildly between a novice nurse and a veteran. It provides an objective baseline to identify high-risk patients.
Now, every study has its limitations. If I'm a resident reading this, what should I be cautious about?
The authors are very transparent about that. First, it's a retrospective study, which always has inherent biases. Second, it was limited to 3 hospitals in one specific region of China, so we'd need to see if it generalizes to other populations. But interestingly, they also noted that they didn't investigate risk factors like the patient's psychological state, social support, or hospital management factors. They focused strictly on the clinical and physiological data.
That's a fair point. We know that failure to rescue often involves systemic issues, staffing ratios, communication breakdowns, not just the patient's physiology. But as a tool for identifying the patient at risk, this seems like a major step forward.
It really is. The core strength here was their strict diagnostic criteria for what constituted deterioration. By being very specific about what a worse clinical state meant, they minimize misclassification, which makes the model's high accuracy even more credible.
So if we look at the big picture, we have 1,576 patients, a 7-to-3 training to validation split, and a winner in the backpropagation neural network. Alara, if you were presenting this at Grand Rounds, what's the take-home message for the surgical team?
The take-home is that we can move beyond the GCS and simple warning scores. We have the data, age, underlying conditions, and real-time physiological measurements to build models that are much more sensitive to the unique risks of the post-craniotomy patient. The BPNN model specifically offers a valuable reference for identifying who needs that ICU bed before it becomes an emergency.
And in an era where ICU beds are a scarce resource, that kind of predictive power is gold. It allows for better resource allocation and ultimately should reduce that 17% mortality rate for unplanned transfers.
Exactly. It's about being proactive rather than reactive.
Well, this has been a great deep dive. It's exciting to see how machine learning and nursing research are converging to make the post-operative period safer for our patients.
Definitely. It's a great example of using retrospective data to build a very practical, forward-looking clinical tool.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time.
Keep operating and keep learning.